Hello, everybody. Let me stop the advanced pages and we will get underway. Thank you for being here. I was going to show you this slide of the work that we have done as a community of practice. This is our 12th month of going over project models once a month as a community of practice. And here's a list that we have accomplished over the last year. And many of you on the call right now have been part of this journey for almost every single one of these project model events. And thank you for keeping the conversation lively and helping us improve our resources and discussions around each of these project models. Today we're coming together for COMM, which is the acronym we use for Community Committee. And let me pull this back a little bit. The COMM model is a generic title given to a health-focused community group empowered to coordinate and manage activities, leading to improved overall community health and strengthen civil society. In most cases, a COMM programming is carried out through existing community health groups or village health committees. And we're going to hear about community committee engagement in World Vision's context for maternal and child health. And specifically, our country example will be from Guatemala, where COMM is one of 3 major interventions being looked at the Child Health Target Impact Study. We have 2 presenters today, Michelle Goodrow, who has been leadership for the COMM working group. She's the WBI, Sustainable Health Team Capacity Building Advisor. And we have Lisa Hernandez, who is the CHTS Country Coordinator for World Vision Guatemala. Before I pass the ball over to Michelle, I would like to open this up in a word of prayer. Very conscious of the fact that in Australia and some parts of the very far Pacific, our World Vision Day of Prayer has begun. And so in solidarity with them and to open our hearts and minds to what He has for us to hear, let me open us in prayer. Dear Heavenly Father, thank you for this virtual table that we can sit around as friends and colleagues to discuss the work that you have put before us. Thank you for walking alongside our presenters in this preparation for this WebEx event. And I ask that you be with our conversation, with our questions, with our hearing, so that you will have us hear the pieces of this work that you need us to pay attention to. In your name we pray. Amen. All right. Because I don't want to take up too much more time. Michelle, our first speaker, I'm going to pass the ball to you and please take it away. Thank you for joining us.
Okay, yeah, thank you very much, Sarah, for that introduction. And actually, you've kind of kicked us off in terms of introducing what the COMM is. And thanks to all of you for being on this call. And I look forward to going through this model with you. In my presentation, because of where I'm based in connectivity, there may be a little bit of a delay in the slides showing up at the time that I am speaking about them, so we'll just, bear with that and be patient with that. Yeah, so my presentation, I'll cover an introduction to COMM. We'll take a look at the COMM strategic framework, which will help us to gain an overview idea of what it is we hope to accomplish and what the various functions and objectives of a COMM may be. We'll look at country readiness. In other words, if a national office is interested in moving forward with COMM programming, what are some of the considerations and steps that need to be worked through prior to implementing? And then we'll look a little bit at implementation itself, what types of capacity building we may work with the COMM on, and some examples, a couple examples of the kinds of activities that COMMs can be involved in. I'll just give you a flavor for that. The resource materials that we have available at this point, what it costs to implement the COMM model. What we'll do at this stage is look at the cost categories rather than specific dollar figures per se. Starting up COMM in World Vision at this stage, what countries are currently implementing and what has been the training cascade to date. And then finally, what are our next steps for wider organizational scale-up of the COMM approach? Okay, so introduction to COMM. First of all, let's just situate where COMM fits in the overall 7-11 strategy. Hopefully this is familiar to most of you that the 7-11 strategy is based on a theory of behavior change that sees the need for intervening at individual, community, and environmental levels. Okay, and so in the 7-11 strategy, we have a core model or approach at each of these levels, and then various possible supplementary approaches as well. So where does the COMM fit? The COMM is our core approach at community level. That's where it fits in the overall 7-11 strategy. However, having said that, it's also accurate to say that the COMM will contribute to the enabling environment and will contribute to some extent to the individual level, and we'll see how they'll do that as we go along. What is the COMM? Sarah helped us with this introduction. It's a generic title given to a health-focused community group empowered to coordinate and manage activities leading to improved overall community health and strengthened civil society. Okay, so generic title, meaning that in most cases we will be working with existing community health groups, and these groups will likely already have a name or a title like Village Health Committee or whatnot. So we're not saying that all of these groups should change their names to COMM. No, it's just a title that we will use internally for our own internal consistency and understanding. Obviously, one of its main objectives is to improve overall community health. I think that's fairly obvious. But it's worth also noting that regardless of what the COMM may do in terms of activities that lead to improved community health, just the simple fact of the COMM's existence as a functional grassroots community group in itself contributes to a strengthened civil society. And we see that as, another objective in its own right. We work in many contexts where civil society is weak. And so, the objective of strengthening civil society is an important one in its own right. In most cases, we will, as I said, be carrying out COMM programming through existing community health groups. Often these will be Ministry of Health-led village health committees or a similar title, which is actually exactly what we would hope to see, that there are Ministry of Health supported groups, and we would support that work. So in most cases, we are not talking about mobilizing or creating new groups. That's not the idea at all. Who are COMM members? COMM members ideally should include representatives of the community leadership, a health facility representative as possible. this won't always be possible given geography and health facility coverage questions, but where it is possible, that's ideal to have representation on the COMM. Community health worker representation, community women to represent the interests of women and gender issues, for example, and other select community members. What are some illustrative functions of a COMM? What are some of the things that the COMM will do? First of all, we want to see the COMM playing the role of a coordinating body in the community, really bringing health stakeholders together, strengthening linkages. So, strengthening links between CHWs and health facilities, links between CHWs and the wider community, those sorts of things, really playing that connecting role as an organizing body in the community. That's one of its illustrative functions. Assessing and tracking the community health situation, and then taking action to respond to such issues as the COMM may identify, responding to barriers to health-related behavior change at community level. And we'll take a look at this in a moment, what do we mean by barriers at community level. We'll take a look at that and see the role that the COMM has to play in addressing those. Convening meetings periodically, gathering stakeholders for information sharing, updates, action planning, so forth. Advocacy, the COMM has a role to play in speaking up around health systems issues. Providing an oversight and support function for community health workers and other community health volunteers. In some contexts, this is actually seen as the main role of a COMM, of a community health group, to have this managerial function vis-a-vis CHWs. And that certainly is an important role of the COMM, one of its foundational roles. But in our COMM model or approach, we actually see the COMM's role as being wider and broader than just the oversight that it can provide to volunteers. So one of their responsibilities, but not the only one. Okay, so if we were to put this all together into a strategic framework, let's take a look at how that would shape up. All right. Under outcome 1 here, which is community systems strengthening or civil society strengthening, you see the many activities that I just listed for you. All of the kind of community-related main functions that the COMM will be involved in, analysis of health issues, responding to health issues, meetings with stakeholders, and so forth. All of the things that can contribute to improved community health at this level of the community. Okay. But then also, insofar as the COMM is involved in advocacy initiatives, and to the extent that community health facility linkages are improved and strengthened, we can say that this is actually contributing to, health system strengthening, enabling environment around issues of health systems. Okay, so we have that as a second outcome in the strategic framework. And then as COMMs are supporting community health workers, In actual fact, they are contributing to the individual level as well, because, you know, it's CHWs who directly reach individuals by going into households. And so, you know, to the extent that COMMs strengthen CHW programs, then the COMM is contributing to strengthening that individual level as well. One box here that I haven't mentioned. In some contexts, not many, but in some contexts, the COMM may also directly supervise community health workers. And this would be in cases where the Ministry of Health or other partners don't have the resources or capacity to do so. The COMM may play that role. So far, we haven't seen that in any of our implementing countries, but it is a possibility. So, putting it all together kind of in summary, the COMM work and the COMM approach mostly really impacts at this community level, as we you know, have set up, as we have said. But we can also see that to some extent the COMM does contribute at the environmental and individual levels as well. And so I think, you know, we can see that the COMM has an important role to play in enabling some of the integration between our core approaches that we would want to see. So, yeah, I just wanted to make that point with the strategic framework and the overview of the COMM functions. Okay, moving on to country readiness. So as I said, if a national office wants to move forward with COMM programming, there are a number of steps and considerations that are needed in much the same way, actually, as country ready, as we have a country readiness process for TTC as well. Same thing, you know, there are numerous kind of national level considerations that need to be sorted out before you can dive in and implement. Ministry of Health dialogue, obviously very important, especially if we're, you know, going to be working with or through or supporting Ministry of Health-led village health committees. You know, if these groups are formally linked to the ministry, then this dialogue has to happen and the programming, you know, needs to be discussed and agreements reached and so forth. So that's very important. Curriculum selection. We have a curriculum for the capacity building of community health groups, but in some contexts, ministries of health may also have materials for working with health groups. And so in those cases, we need to, you know, make decisions about what to use. In most cases, the best practice is usually that if MOH does in fact have something, then we would want to support that rather than working or setting up something in parallel. But you know, there can be value in sitting down and doing a curricula comparison and maybe using some of the materials that we have to fill gaps or supplement what the Ministry of Health has. So that process has to be worked through and those decisions made in terms of what curriculum to use. Which community group is the COMM? Very important that this gets sorted out before implementing, because if we think from the perspective of our poor field staff who often will encounter more than one type of community group on the ground, some guidance does need to be provided in terms of, you know, so what group is the COMM? The principle, obviously, will always be that if there is an MOH-linked group, this group will always be selected as the COMM or identified as the COMM. There may not always be MOH-led community health groups, however, and so we've actually sat down and sorted through many of the various scenarios that staff may encounter on the ground. So for example, what if there's a CCC? You know, what should we do then? Is the CCC the COMM? Should there be a subcommittee of the CCC to become the COMM? All those various permutations and scenarios that we may encounter on the ground. We've provided some guidance on how to work through those, and those decisions need to be taken as part of country readiness. Who's going to work with the COMMs? You know, with their capacity building support, mentoring, and so forth. Strictly MOH, are these, you know, will it be a strictly MOH-led program? Will we be supporting MOH? Will it be mostly World Vision partners? You know, so those questions of implementers, implementing parties need to be worked out. We have a log frame and a monitoring system for the COMM model, and those will need to be contextualized to each setting. COMM aim, what do I want to say here? What we want to do here is follow the example of the CHW AIM tool, which some of you may be familiar with. This is a tool that a unit within USAID has come up with that defines and identifies the necessary elements that must be in place in order for a CHW program to be well supported and functional. Okay, because I mean, like, we will often see cases when volunteers are trained and then expected to simply go out and work without any of the necessary foundational kind of support elements that are needed, without any of those being in place. And so the CHW AIM tool is meant to be used to assess the degree to which those elements are in place, and to you know, make a plan for strengthening such elements as may not be in place. And so we want to develop a similar tool for COMM programming, because I think we're looking, you know, at similar issues. COMM members are going to be volunteers. What do we need to ensure is in place to ensure that these volunteers are sufficiently supported, functional, sustainable, so forth. So this is under development, and when it's ready, we would hope that countries would carry this out prior to implementing, you know, to make sure that the program is well structured. When all that's done, all that's sorted out, then facilitators can be trained. And who are the facilitators? Again, this can be World Vision staff, MOH staff. Yeah, so those are the country readiness steps. So then COMM implementation, when we get into the capacity build, when we start working with COMMs, you know, and want to do perhaps some capacity building and activity planning with them, what does this look like? First of all, we will do a light appreciative assessment of the COMM, because, you know, again, we're usually going to be working with existing groups, and so these groups will have, you know, ideally already have received some capacity building and already have some experience in certain areas, and so those things need to be taken into account before capacity building plans are laid out. So the appreciative assessment, the light assessment comes first, you know, so that then capacity building plans are adequate to the group in question. We also, our field experiences have shown us that the COMMs will normally need some background in the 7-Eleven health content basic information around the 7 and 11 health practices. We've seen that, you know, that these are community members, you know, and they often have a lot of questions around these areas. So we're currently putting something together to respond to this need. A lot of people are involved in this. Actually, there are 18 people involved, one for each area. And we're putting together something in the form of questions and answers that can be used with COMMs to help them, you know, just understand the basic information around 7-Eleven. Okay, so that would be a beginning. And then in terms of technical training, the training that will help them to carry out their functions, training in how to carry out a root cause analysis of health issues in the community, and then how to take action to respond to those issues and to respond to barriers that are identified. So far, our experience has shown us that getting this far takes about 5 days of training. This is partly due to the fact that of the various capacity building sessions, the root cause analysis is the most involved. And so once that's kind of out of the way, things move a little more quickly after that. Ongoing tracking of community health status, their linkages and their being able to serve as a coordinating body, training in that, supporting CHWs, everything that's involved in that, reporting, you know, holding periodic stakeholder meetings, perhaps creating and maintaining some sort of a health board with information, those kinds of things. We approximate, or we estimate that to finish that up would take an additional 3 or 4 days. That's our estimate to date, without having had extensive experience with this yet. And then COMMs may need some additional training as appropriate. Organizational capacity building will often be a need because we're talking about a community group, right? A community-based organization, so to speak. And so apart from the technical areas or the action-related skills that the COMM will need, there will also be sort of internal group considerations to deal with or to strengthen. Fortunately, World Vision has pre-existing OCD materials, so those can be brought in as needed, on an as-needed basis. We hope that the COMMs will be involved with CBA, local level advocacy. And if it is the case that the COMM is directly supervising CHWs, then they'll probably require supervision training and, you know, TTC training. If they're doing TTC, they need to be trained so that they can adequately supervise. That last one would only be in cases where they're directly supervising. So that's the capacity building that can be carried out with COMMs per any one group's needs. And then I just wanted to give you a bit of a taste of what some of their activities may look like. Sarah, can you just give me a time check? How far am I right now?
10 more minutes.
10 more, okay. Yeah, so this is an activity that we carried out here in Swaziland with the group. And so the COMM identified some health practices that they wanted to look more deeply into, and those are listed there on the left. And then they were able to identify some of the common barriers to practicing these behaviors, and those are listed on the cards to the right of each practice. And the color coding is interesting here, because what we really talked about is the fact that many barriers that a family may encounter to practicing a given behavior can be dealt with at the household level, you know, between CHWs and the families directly. Barriers having to do with like beliefs or fears or preferences, that sort of thing, can often be dealt with right there in the household. But there will be times when families will experience or have barriers that can't be solved right there in the household, that the CHW is unable to help with. And those need to be elevated to a higher level. And so those are the ones with the blue stickers. So, you know, if there are issues of access to water, for example, or cultural norms, for example, then these are the types of barriers that are better addressed at community level. And this is where the COMM comes in, and the COMM can come up with ideas of actions that it and other community members can take to try to address these types of barriers. This is actually a great activity. It's very understandable by the COMM. They're very clear in terms of you know, what barriers are best addressed by themselves. And so just to give you a taste of some of what we are doing with the COMM. I'm going to run out of time to give you more of a taste, but you can go through this presentation on your own afterwards. But here, what I'm showing you is the way that we work together with the COMM to kind of unpack what are its roles vis-a-vis CHWs compared to the roles of the CHW's direct supervisor, you know, and really kind of sorting that out and helping the COMM to understand the types of ways that it, as a community body, can best support CHWs. In the meetings, like periodic meetings that the COMM will hold with health stakeholders, we work with them on different ways of kind of simply presenting health information. So these are some examples of exercises that a COMM experimented with in terms of how do we present health information. What resources do we have available at the moment? We have a description and guidance for design document. We could also call this the COMM toolkit if we wanted to. This document is pre-implementation. It's for program setup, covering all of the country readiness considerations and so forth. It's for designers, program designers, and so the country readiness guidelines, scenarios for COMM selection, you know, those various scenarios that I was explaining. The strategic framework is there, sample log frame is there, minimum standards for quality COMM programming are laid out there. Alignment with DPA, I don't have time to get into this, but very important area to be clear about with our staff. So that's explained in the document. And then guidance for the COMM AIM exercise when that is ready. Training materials, what do we have? We have a trainer's guide for training facilitators, a facilitator's manual for training COMMs, and these two are just about through publication. They're just about ready. Publishing has them and they're almost done. I'm going to have Sarah put something in the chat box about us needing a new photo. Sarah, can you help us there? The Facilitator's Guide to 7-Eleven Health Content, that's the one that I was explaining previously that we're currently putting together, questions and answers around the 7-Eleven health issues. And in fact, this can have wider applicability than just to be used with the COMM. This will likely have many possible uses. And then OCB materials are pre-existing. So those are the training materials that we have available. The monitoring system, we have 4 simple monitoring tools and an indicator tracking spreadsheet. These are just about done, kind of going through final testing at this point. And I just wanted to show you this to make a point. When Polly Walker and Sue England gave a presentation on TTC, they showed this slide which categorizes the resource materials that are available for TTC. And if we were to compare it now in this slide with the resource materials we have available for COMM, it's all quite similar. We don't have the visual aids, the storybooks that TTC has, but otherwise we're following really a very similar format in terms of what we are making available to support the model. And the description and guidance for design documents, which I said we could also call the toolkit. We were very intentional about trying to align it as much as possible to the TTC toolkit so that our field staff, as they're receiving these things, they begin to see some consistency in what it is that they're receiving. So I just wanted to make that point in terms of the resources and their alignment with TTC resources. Let me quickly skip to where COMM has started up to date. To date, COMM is only being carried out in the 4 CHTIS operations research countries, which are Guatemala, Kenya, Zambia, and Cambodia, and the countries that are supported by the Irish Aid AIM Health grant. And Magnus Conte is on this call, and he can tell us in the chat box. I did not include in this map Sierra Leone and Tanzania, which I should have. He updated me on that yesterday. So the AIM Health countries, Mauritania, Uganda, Sierra Leone, and Tanzania. These are the countries where COMM is currently being implemented. It's interesting always to realize that the contexts are different in every country. Kenya and Zambia, for example, we're working with existing MOH-linked community health groups, whereas in Guatemala, these don't exist, and so groups are in fact being mobilized. Differences in terms of what curriculum is being used, and we're always going to see that, and it's important to understand that contexts will be different, and the ways that the model is implemented will be different. So just to give you a little sense for that. The training cascade to date carried out a training of trainers. I'm getting a time call, 5 minutes, okay. Training of trainers in June. However, this was only for representatives of the CHTIS and AIM Health countries, and those individuals are only available really to carry out TOFs in their own countries. They're not available for deployments elsewhere. And so what that means is that right now we currently do not have a pool of COMM trainers. There's just a couple of us who could do a COMM training at a pinch, but we don't have a deployable pool of trainers. The TOFs for the CHTIS and AIM Health countries have pretty much been achieved. You can see where that stands right there. I'm not going to go through this. And so what we're needing then right now in order to scale up COMM more widely across the organization The resources are pretty much ready and in place, and they've been tested and revised and, and all of that. So what we need now is a pool of COMM trainers who can be available to carry out TOFs in select countries. So to that end, we're going to be holding a training of trainers in FY15. This will be a blended learning course that will include pre-event virtual assignments, and then in a country yet to be determined, we will hope to do the classroom and the practicum back-to-back, and that would be in a country that's ready to get going with COMM implementation. That's our plan. And then with a pool of COMM trainers, we will then be able to respond to requests for TOFs from national offices wishing to move forward. So we're going to be soliciting, expressions of interest from folks who may want to become COMM trainers, meaning that, you would be able to perhaps carry out 1 or 2 TOFs per year, one TOF, let's say, per year in a national office needing it. So more information around that will follow as the time nears. And this is where you can get information about the model. And I think with that, I am out of time and can take some questions. Thank you. And what I'll do as we kind of work through the questions, let me just flash the costing categories slide, and you can just look at it. These are the categories that we expect that there will be costs for when implementing COMM. Yeah, so I'll just let you look at that. And maybe, Sarah, you can help me with the questions.
Yeah, and it looks like our slides are trying to catch up to that costing bit. So we'll wait a minute, and hopefully that will flash in a second. On barrier analysis, there's a question from Don. Did you do barrier analysis surveys to discover the barriers, or did you use some other tool in your COMM implementation?
Yeah, thank you, John. The barrier analysis survey, like the DBC that we know of, is quite in-depth, as you know, and is useful if there is one particular behavior that is problematic and we really need to try to uncover the barriers for that. Since as part of the root cause analysis, the COMM is actually going to be looking at numerous health practices, not just one, they won't be able to do in-depth DBC for each health practice. So instead, we train them to do focus group discussions with a sufficient sample size to have some degree of confidence in the results. And then the analysis is what's the word? Well, it's geared so that the barriers are identified out of that and quite clearly flagged. So yeah, it's a lighter process than the DBC that you're doing.
Second question, and just for our audience so we know, we're pausing for questions here for just a few minutes, and then next up we'll have World Vision Guatemala's implementation experience. And I'm seeing a couple of these questions that we'll take now, and some I think we'll need to pause for after Guatemala because I think those questions will be answered in that presentation. So Michelle, another question for you is one of the concerns on this model's implementation is the silo approach that you can experience in the field. Any comments on how to address this issue?
Well, we can understand silo, I think, in a few different ways. Silo in terms of independence vis-a-vis TTC and CDA, in other words, with relation to our other core 711 approaches, I think we've actually been quite careful to make sure that our core approaches are not siloed. and actually do have reasonably good integration, and I was trying to show that a bit when I was showing the strategic framework and how the COMM can contribute to other levels. However, yeah, insofar as the COMM being a health-focused community group, and what we're seeing or what we're doing at the moment is really zeroing in on maternal newborn child health, the pregnancy and 0 to 2 cohorts or age ranges, is an organizational choice, you know, for now. But the COMM functions are generic in nature, meaning that over time they can apply the types of activities, analysis, barrier response, etc., to issues moving beyond MNCH. So, for example, it can be applied to HIV-related issues. It can be applied to adolescent sexual health, for example. And in fact, in countries where we're working with Ministry of Health linked groups, these groups may already be addressing other parts of the health life cycle. So all of that is very possible through the COMM model. It can be used to address any range of health-related issues. In terms of siloing with respect to other sectors, this is where I would need to get into a bit of discussion around how this aligns with the DPA, the development program approach that some ABPs are doing, and how health working groups, which in this case we mean the COMM, need to be bringing in, you know, partners and stakeholders from other sectors as well. And so that kind of philosophy, I suppose, there is the potential for that to be worked into COMM programming, but I don't think I can explain that in full detail with the time that I have.
What has been the experience of establishing or supporting COMM where CCCs exist, as in Kenya and Zambia? And can the COMM take on HIV care and support issues that are core to CCCs, like home-based care that is quite health-related?
Yeah, yeah, good question. And I think to fully answer this, we would need the Kenya and Zambia team to be with us. I know that in Zambia, they're still working with the MOH to, the Ministry of Health has neighborhood health committees, and these are the appropriate groups to work through as the COMM. Now, as Stuart notes, not only are there NHCs, neighborhood health committees, but there are also CCCs in many areas. How are those going to, you know, how should those be handled together, or what should be the best approach? Again, Zambia is still working this out with the Ministry of Health, and they've been given the scenario guidelines or the scenario options, and they'll need to make some decisions in that respect. It's possible to umbrella the CCC, for example, to encompass NHCs as subcommittees, or perhaps vice versa, umbrella NHCs to encompass CCCs as subcommittees, but those choices still need to be taken with the MOH. So to give a more complete answer, we would need to get back to their team and see where they are with that.
The next question I have is, in relation to COMM cost categories, what examples do you have related to sustained COMM without external World Vision funding?
I'm just reading the question over. Okay, well, so far, as I showed in the map, we're only getting started with COMM programming. So we haven't reached a point where, you know, we're letting go of it and wanting to see them be sustainable. I think short answer to that is that we would want to see the MOH links as far as possible, and with the MOH really holding the responsibility for continuing to support these groups. One of the things that is an advantage of COMM in relation to in comparison to TTC requires the visual materials, and there's a great deal of like ongoing materials reproduction that's needed for that can often be a question mark in terms of, you know, what happens after World Vision projects finish, who will do that ongoing materials reproduction. We don't need that for the COMMs. There aren't heavy loads of materials that need to be reproduced on an ongoing basis. So the type of ongoing support that will be needed will be, you know, along the lines of field support visits, support in the quarterly stakeholder meetings, for example, assistance with monitoring functions, and without having had concrete experience in these areas yet to date, my sense is that none of this is terribly costly.
I have one last question for you, Michelle, before we move on to the Guatemala experience. And I see several other questions here about measurement on impact and documentation. And I think those questions I'm going to pause. They're not forgotten, I promise, until after the Guatemala implementation experience. But here's one last more general question for you, Michelle. Can you speak about how COMM works with child monitoring for sponsorship? One of the aspects of sponsorship and programming is related to community-led monitoring, where the community is leading the child monitoring. Can you speak how COMM works with or to help support child monitoring in these cases?
Yeah, thank you. That's a good question. For the most part, we see the COMMs really responding at the community level, undertaking activities that will best address kind of higher level constraints, issues, and barriers, and that the individual level work with children and with families is normally carried out by various cadres of volunteers. And so where the COMM does have a support function vis-a-vis CHWs, that actually can expand or should expand to be a support function for any health-related volunteers that are active in the community. So I think my initial answer would be that it would still be the volunteers or the individuals who are responsible for the child monitoring who will maintain that function. But the COMM, in its kind of oversight and coordination linkage capacity, can really play a useful role, I think, in kind of aggregating some of those results and presenting them back in meetings, such that it's not volunteers kind of working in isolation, but having this oversight and support from the community group that can kind of pull it together, pull results together, present results to the wider community, take action at a higher type of community level, I think is the way that the COMM would participate.
Thank you, Michelle. You're off the hot seat for a few minutes. You get to take a breather and go through the chat box a bit. We are now moving to Lisa Hernandez from World Vision Guatemala, EHTIS Country Coordinator for the Guatemala implementation site. And as with all of our other project models, we think it's, and as these questions about implementation continue to come up, we like highlighting a national office experience in their implementation. Lisa, why don't you unmute yourself, and we will check your audio.
Hi.
Hello, good. All right, I'm going to pass you the presenter ball. Thank you for joining us and for sharing your beautiful country. I had the privilege of being in a few months ago. Your experience in COMM. So start as you are ready.
How did I change the slides? Just down?
Sure. At the top of the page, just above your title, there's a text box with a 01, and then there's an arrow to the right and to the left. If you click the arrow to the right, you should move it forward.
Okay. Thank you.
Thank you.
Well, thank you everybody for being here. I have written some of the questions on the chat box, and I'm sure that some of the questions will be answered during the presentation, but please, if you have more, feel free. Just a special request, try not to use a lot of acronyms, because remember in Spanish we have our own acronyms, so it's kind of complicated to remember all of them. So if you have a question related to an acronym, please use the complete word. Thank you. Okay, this is just a few background what's happening in Guatemala. We have a population of 14 million people. The infant mortality rate is 23 deaths per 1,000 live births. The life expectancy is almost 72 years. The health expenditure is 6.7 of the total budget. And there are almost less than one doctor for each 1,000 population based on the last census made from the MOH in 2009. 54% of the population lives under poverty line, and if I may add something, we have almost 50% of chronic undernutrition in our children. So the background programming in Guatemala is normal, and please, I will ask for Ramon Soto as he's joining us if I'm forgetting something, because he's expert in the health issues in LACRO. In Guatemala, we have a normal health programming in our 32 ADPs, guided, of course, based on the 7-11 strategies. These are including like nutrition-focused programming. We have, of course, a growth monitoring. We have something that is based on like AKA PD Heart. It's called Olla Común or Common Pot, and it's based, of course, in the PD Heart. And we also have referral for acute malnourished children. In the health programming, we have monitoring of vaccination of children under 5, capacity building for Madres Dias or Mother Guide. The Mother Guides are the volunteer personnel that is actually working where the ADPs are located. And they are our strength in developing many of these programs. And we also have programming in child development. It's called Centro de Desarrollo Integral de la Niñez, CEDINES, and in English is more like Essential Childhood Development Programming for children between 0 and 6 years old. During that training, the children are also receiving some basic messages in health and nutrition also, of course, through the mothers. And we also have the contact special programming like Chagas disease prevention and some malaria, but they are located based on different locations from the ADPs. For you to know, the Child Health Target Impact Study is a 5-year quasi-experimental study conducted in 2 countries in Africa, Kenya and Zambia. One in Asia, it's Cambodia, and Guatemala was selected among the 14 offices in LACRO. The goal of our study is to evaluate the World Vision Score package based on the 7-11 strategy. And as you may know, we have 3 models to implement: the TTC, the COMM, and the CBA. Now we are based only on the COMM improvements and the way we're deploying it. The COMM is one of the 3 interventions, and because Guatemala were selected for the CH test, that's why the COMM was actually, Guatemala's national office receiving the COMM training, and that's why we are implementing that now. I was receiving two trains last year, the theoretical part and the practicum. And now, in March, we have done the TTC, the TOF training here in Guatemala. Michelle Gadro was joining the training, and we have trained some of the ADP's personnel and the people that are actually working in the CHTF. Okay, here are some of the pictures from the TOF. As you may know, we have 4 ADPs participating in the CHTF, and during that training, 3 staff for the CHTs were involved. The other one was resigning at that moment, so that training would happen after that. A total of 13 staff were trained, 5 from CHTS, 6 from other community work from the ADPs, and the manager of community relationships and other was the manager from the Child Health Now campaign. The only ADP that was not there because at that moment the person was resigned. This person was hired after a new person, and this was trained afterward in June. The mobilization for COMM in the 4 ADPs began in June 2014. Here are the pictures of the people that were trained during the TOF during the first week. The second week was different because the practicum was actually done only in the CHTS team. And here you can see the pictures of our facilitators and from Andrew Cunningham. As you may know, Guatemala is part of the Global Health Fellow Program, and he was our first person that came, and he helped us a lot. So during that practicum, we held it up with 10 people from the communities. Actually, they were leaders from the community. Some of them work in health, some of them work in development. But during that training, we have a very good experience, and that was our first experience, actually, like doing a practicum. Here is the status of some mobilization in trainings in our 4 ADPs. Here are the numbers, the names of our ADPs. In Tinamit Hunam, we have 1 facilitator also in a path. Those 2 ADPs are part of the comparison site. Comapa and Nuevo Amanecer are the ones that have been implementing the 3 models, and therefore they have 2 facilitators trained. So far, we have a particular number of COMM aim by the end of FY14, and we accomplished to have more than we were expected. So in Tinamit and Apaz, we have 3. In Comapa and Nuevo Amanecer, we have 2 COMM already formed, and all of them have already begun with the training. There have been some implementation challenges, as you may know, because sometimes there are a few challenges like the one that they were mentioning in the chat box, and here I will mention some of them. When we were doing with TOF, we have this specific number of COMM that should be formed based on the number of people living in those areas. But there are some unknown contextual factors, and here are some of the things that we didn't consider, because we didn't actually know at the moment. One of them was not enough staff to implement the model. There are some turnovers from ADP staff that originally was trained as COMM facilitators, and some of them are resigned. Another challenge is the distance between the proposed COMM meeting places, because on the map they look, even if they look far away, is when we actually get to the communities and we find out and we try to engage people, there are some villages members that were unable to travel from one community to the other. So in this case, we need to form 2 separate COMMs in each community. Another important issue that is happening in Guatemala, as you may know, is safety concern for staff. There are 2 particular ADPs that we have in some problems with safety reasons. One is a path. So there are some communities that are called red areas, and the ADP decided that the staff will not be safe working in those areas. And in San Juan, what is happening is the COMM meetings have already started, but the government banned some public meetings during the last 3 weeks. So even that we are actually running COMM trainings, we need to stop that because it was a government law. I can go deeper if you want in that information. There are some other challenges, like in May of this year, the government stopped supporting health post extensions run by NGOs at community level within our ADPs. So this funding stopped, and especially in the area in Jutiapa where APAS and COMAPA are based, the access to the health services are reduced. And for instance, if you want me to give you an example, the vaccination monitoring, the vaccination access, the vaccination cards are not being updated because they have no access to vaccination. Another example is that prenatal and postnatal care has been dropped. And so far, these are a very strong challenges that we have been facing. And how do we face that, if you want me to answer that? Well, as you know, Guatemala's World Vision have a memorandum of understanding signed with the MOH this year. And based on that, we are coordinating, having coordinations with the MOH at local level to find out what is actually happening. And so far, we managed to have a coordination with the stakeholders and including MOH to give a reason, give answers to all these problematic situations that have been happening at ADP level. Some implementation that we have been, I think we're a success, is that well, COMM is a new model here in Guatemala and especially in World Vision Guatemala. We have been working for a few years with community organizations, but train specifically in aspects based on 7-Eleven is something very good, and the people are very happy to have this training because we are having them mobilized not for political reasons, but to improve community health, and that's a plus here in Guatemala. Also, the ADPs have planned more mobilizations and have been started our trainings. And all COMMs, including the extra ones, have completed training on schedule. So we have scheduled trainings based, like Michelle was mentioned. Not all of them, even if they are health related, not all of them are people that actually work in health. Some of are just community leaders, religious leaders, people that work in development in their communities, people that are actually working in the government at local level. So all of them are very engaged in the health aspect of their communities, but not all of them have the same background. So based on that, we are beginning the trainings based on the 7-Eleven strategy and the curricula that Michelle was mentioned. And that's it. If you have any questions, Sarah, please.
There are a few questions about COMM implementation and measurement. So within the Child Health Targets Impact Study or overall for COMM, how do you measure impact on community strengthening through the COMM?
We are not at that step yet. Remember, we have formed our COMMs in June, and we have started training in July and August. So far, we are just focusing on following the schedule that we have to train them on 7-Eleven strategies. What I can tell you is that normally these trainings are based on this schedule, and even some of the members in these communities, there are different skills. So sometimes they want to focus more in the 7 than in the 11. So that's where we are trying to contextualize and have it like adapted to each of the COMMs. Anna Pallen wants to jump in. Please, Anna.
Yeah, in the design of the Child Health Targets Impact Study, we're not anticipating that we will actually measure much of the impact of the COMM model. It's being implemented in all of the study sites, the intervention and the comparison sites. So much of the effect of it will sort of be canceled out based on our study design. But what we do hope to see is sort of the synergistic effects of implementing CVA, COMM, and TTC together. You know, COMM is really sort of a backbone structure that supports CVA and COMM. I mean, CVA and TTC are speech study programming. So to answer your question is, the CHTIS is a difference of difference analysis, but we don't anticipate that we'll be able to monitor, measure much of the impact because it was the ethical give and it's being implemented in all the study sites.
Thank you, Anna.
Thank you, Anna.
And this next question, and this might be to Anna as well, and to Michelle, well, to any of you as presenters, what types of documentation field experiences moving forward is going to be collected?
Well,
yeah, I maybe, Lisa, I'll just say that we've developed monitoring tools and monitoring system for COMM, which Michelle would probably be the best person to talk about that. But that we're also doing robust environmental and just documentation of what's being done for CHTIS. And Lisa, you maybe can add, I don't know.
Yes, answering that is that, of course, we have some tools developed by Global Center experts, and we also have these like very simple tools that you can actually have the attendance of the people who were there, and we have this specific chart so we can check if they are there and if they actually are receiving the information and how well they are understanding this information. Because one is to be seated and listen, and one other difference is to see if you are actually understanding what you're receiving. So we have two different types of tools, quality and quantity measurement. So that's maybe that's an answer. I want to answer the question that have been in the chat box from Ramon, and another Ramon knows this because he understands our environment. You know that it's very tricky to try to have a group of 15 or 20 people hold together for a week. It's impossible in our conditions. So how do we handle the training? Well, we have, based on the identifications of the problem that they want to be addressed, we have this scheduling, and what we normally do is have them for 2 or 3 hours for 1 week. It's like once a week, so 3 hours in a week, and that's the way we normally handle our agenda. Because remember that they are volunteers, and we cannot actually pay them an estimate to be there. So we need to adapt to their environment, and we actually are the ones that move to their community. They don't come to the ADP. We are actually going to their communities, and we are scheduling these trainings 3 hours a week. Of course, it's delayed, but this is the only way that they can give us time. Remember, there are people that are actually working in their communities. Most of them are people that are farmers or agriculturists, and they are working their fields. So actually, they are giving us this humongous amount of time, like 3 hours a week is a lot of time for them, and we are adapting to their schedule. So some trainings are happening in the morning, some are happening in the afternoon, and even in one particular group in Jutiapa, we are doing the trainings on a weekend.
Yes, thank you, Lisa. I did not mean to skip over that question. I was seeing Michelle was addressing a bit of it in the chat. But for those people who might not have been following the chat, Michelle, did you want to give a recap of the discussion in the chat box about volunteer time for COMM?
Well, I mean, I guess just that we are very aware of this and recognize it as a concern, to some extent, working through volunteers is always going to be a somewhat thorny and fraught kind of assumption that we rest our programming on. And what if volunteers don't want to volunteer? What if they don't want to continue to do it? You know, that is always going to be kind of an underlying risk, I suppose. Knowing that, however, we're trying to do as much as we can to mitigate that, work with it, acknowledge it. I think, and again, I think the COMM tool, sorry I couldn't get into more detail about what exactly that is, but it's 15 elements such as supervision, incentive systems, opportunities for advancement, recognition, training and professional, things like that, and things that can contribute to volunteers feeling like they are also benefiting from their volunteer work are incorporated into this tool, and we try to put systems in place to address those as far as possible, as reasonably as possible. And I think that maybe the best we can do. Also, let me just make mention of the fact that there has been a document put out by World Vision guidelines around working with volunteers. So we also need to go through that and base a lot of what we do around the principles that we can find in that document. But I mean, it's just all very, these are all legitimate concerns, and that's what I can say.
Magnus has Magnus.
Yes, Sarah, thank you. And thank you so much, Michelle and Lisa, for your presentation. As some of you are aware, the AIM Health Project program, which is being implemented in 5 African countries, 2 in West Africa, that is Sierra Leone and Mauritania, and 3 in East Africa, Kenya, Uganda, and Tanzania. We've had varying experience in implementing this model in these countries. Part of the experience we've had is the fact that there were already existing structures in at least 4 of the countries. Mauritania did not have any community health existing structures, but the program has been able to establish new community committees within the operational areas. However, in those countries where COMMs already existed, they were operating under the Ministry of Health. And in the 3 East African countries, the Ministries of Health already had policies and guidelines in terms of the selection and the operation or functioning of these community committees. And part of the challenge has always been around how do we sustain, or how the Ministry of Health sustain these community committees. In Kenya, Uganda, and Tanzania, there is a stipend provided through the Ministry of Health for the community committees. For each time that they meet, they get a stipend to cover their transport, to cover their participation, and any other expenses related to their meetings. If they have to hire a venue, if they have to provide food. That in itself presents a complication. Whilst it acts as an incentive, it has also acted as a disincentive, because the ministry is not always able to provide that allowance for them. And in the absence of the allowance being provided, the community committees do not always meet them. So those are some of the observations. In terms of the training and capacity building, we found that the Ministries of Health also had existing curricula for training community committee members, but they were not robust enough compared to the World Vision developed curriculum for training of community committees. So we've had to do a lot of capacity building. And of course, the issues that have been raised in the chat box about duration of training, about the cost, about the flexibility, taking into consideration that these are community members, volunteers who have other jobs and families. We've had to adapt, different strategies for accommodating their needs and their time availability in terms of how we organize our training. So these are some of the realities on the ground. Having said that, in countries where the community committees have been trained and are functioning well, we've seen a great uptake in terms of a lot of the TTC messaging that we're giving, participation in CDA activities, as well as uptake of our PDHAT sessions that the community committees have been putting up for communities. I think it's a great structure. I think it's very challenging to try and get it off the ground where it's not in existence. Where it's in existence, to reconstitute those groups which have not been functioning well, like in the case of Tanzania, it's quite challenging. But once you are able to mobilize them enough and for the community to accept ownership for assessing their health needs and for developing action plan to champion the needs, or if you like, to fight for the needs of the local community for health improvement, we've seen a great uptake, and we've seen increasing support for community health workers as well. So no doubt it's a good model, but there are challenges, but there are also significant benefits that we've seen across the 5 countries where AIM Health is operating. I hope that's a useful contribution to this debate.
Yes, Magnus, thank you for those comments, and I think it speaks to some of the questions that remain in the chat box about if COMM is supporting strengthening its community structures, how do we produce evidence related to this outcome? And those upticks of programming perhaps is one of those ways to move forward. Faye has a question here. Have we considered including adolescents and youth as part of these committees? I like that question.
In the case of Guatemala particularly, we have received the CBA. Remember, the CBA is one of the models that we're implementing, and the CBA here has been working a lot with the youth network that World Vision has been working for several years. So yes, actually that's one of their questions. When we presented the models, and especially TC and COMM, they want to see how can they be involved or engaged in these models. So our next step is to involve them in one of the COMM trainings and see if they can also be part of one COMM. Maybe, of course, if they don't actually have like a, maybe not much to say, but I think we can take them under consideration, and they have a different point of view of the same situation. So I think it's very valuable that they're there forming. We're going to start only in one particular area, so there where the strength, the youth network is very strengthened, and we will include them in the COMM training. Yeah, so far that's what I can say on the youth networks.
Wonderful. Yes, and Tina Monique is affirming that youth are great in these types of programs because they bring forth that youthful energy and generate lots of data on the time sensitivity. I'm looking at the chat box. Faye, you had one other question that remains unanswered, and your question was, have you connected with the Greenfields experience in the South Africa region? And there might be several people on this call who are not familiar with Greenfields. Do you want to unmute yourself and speak to us why you think Greenfields is relevant to CH6, or how you feel Greenfields is relevant to CH6? I mean, COMM, sorry.
Okay.
Oh, sorry. Hi, good morning, everyone. Yeah, well, I just briefly learned about the Greenfield experience where they have community actually be driving the it's sort of like a modification of the DPA where they have CBOs, but they are generated from what they call change agents from the community. And one of the things that they have developed are basically locally grown tools for assessment design, and I think even monitoring. So I was just wondering if this is something maybe that could be explored. I am sure that Miriam Chan might be more familiar maybe than I do. Miriam? Is Miriam still there?
Maybe.
Yeah, but okay, but maybe something to take a look at, because I was told that it's cheaper than the usual things that we do in communities, and so I think there will be some sort of a study to look at the costing for this one. So it's very much like I said, locally grown CBO type of groups. And they are also provided organizational capacity building trainings, but it's not the little more formal kind of, I'm not saying not formal, but rather it's really based on culture and language and things like that. Yeah.
Great. Thank you, Faye, for that connection from one program to another.
Oh, there's Miriam. Yeah.
Miriam, she's here, but her mic isn't working, unfortunately. So perhaps the
you could write up
team
something.
you can follow up. We are running towards the top of the hour, and I want to stay on time here, respect all of our time. I am not seeing any unanswered questions in the chat box, and no hands are up. If you have a burning question that you want to ask, go ahead and raise your hand or type it in that chat box. I'm pausing, and then if I don't see anything, we'll move to a few announcements. All right, I'll move to announcements. Again, thank you, Michelle and Lisa, for your presentations and sharing your experiences with the community committees model. I've shared in the chat box a link to the start of a COMM webpage on WV Central. As Michelle noted, we have several guides that are just finishing up the publishing process, and they should be done at the end of this week. So I'm going to hold sending these resources from this meeting out until early next week, because I'd like to be able to link everything up on the page and send that out to you. So as I said, the presentations are up on that COMM page that you can access, but the official recording and notes will come out early next week when we can get a hold of those publishing pieces once they're finished. GTRN. We are all writing our FY15 performance agreement. Please put GTRN and your SME qualifications on your learning and development for your performance agreement. That will move forward. Our goal is to identify each of you as the subject matter experts you are. Don't forget, if there's still time, in about 1 hour a week, you can finish up the Advocacy eLab, A Course for Change. It's an excellent online advocacy e-learning tool that the MIR region developed, and Stefan German's team has generously donated 2 iPad minis for 2 people who complete it, who are part of our community of practice by November 7th. As I said, this is the last of our FI14 project model series, but never fear. We feel like there's been great positive feedback from each of you. We're continuing this in FY15, and some of the programming elements and models that we're looking at moving forward in the first quarter will be healthy timing and spacing of pregnancies, birth registration, home-based fortification, and many more. So stay tuned for more dates moving forward. As always, we have project model information on our COP page. And this is my last slide. We have some upcoming dates for COP conversations. Child Health Targets Impact Study, which the Guatemala COMM is part of, are releasing their baseline results. Very exciting. This date of 14 October may be moving a little bit, but in the next month we'll be having a series of 4 webinars to talk about the results of the CHTIS baseline study. Please also note a few other webinars coming up in the next few weeks, and we look forward to seeing you on the WebEx. Thank you, everybody, for participating and keeping the chat box lively. See you soon. Have an excellent day of prayer. I'll be praying for each of you.
And please remember our colleagues in West Africa tomorrow.
Absolutely, of course.